Hi, everyone, and welcome to the Minimal Residual Disease Breakout Session, or MRD. I am Sarah Quinlan of the Lymphoma Research Foundation, and we are thrilled to have Dr. Matthew Davis presenting on this topic today. Dr. Davis is the Director of Clinical Research of the Division of Lymphoma at Dana-Farber Institute Cancer and an Associate Professor of Medicine at Harvard Medical School. After the presentation, we'll have plenty of time for some questions, and at the bottom of your screen, you'll see the Q&A button. Please submit your questions there at any point in that box. Thank you, Dr. Davis, for taking the time to present today. I'll now hand the program over to you.
Great, thank you so much. Happy to be with you all today from Boston. This is not the view from my office behind me. I wish it were, but this is about what the weather looks like today. So a lovely fall day here in Boston, and happy to spend a few minutes with you on this important topic of minimal residual disease in CLL and SLL. MRD, as it's called, has been around for a while. We've been talking about this for actually a couple of decades now, but the relevance in CLL, I think, has never been stronger for MRD, and I'll try to kind of go through some scenarios where I think MRD is very important. I do think one thing to highlight, even just right from the beginning, is there's other scenarios in CLL treatment where MRD is not as important. And for example, one thing that I like to mention is that patients who are doing very well on the BTK inhibitor drugs like ibrutinib or acalabrutinib, they can do very well without achieving this undetectable MRD state, as long as they continue to take their drugs. So if you're a patient like that, this MRD discussion may not be as directly relevant to you right now. But as we'll see with certain other types of therapies, particularly the Venetoclax-based therapies, where we're giving it for more of a time-limited period, MRD actually becomes more relevant. So with that as a little preamble, I'll just mention some important disclaimers. These are my speaker disclosures. I do consulting work for various companies in this space. Probably most relevant to this presentation is work I do with AbbVie and Genentech, who make Venetoclax, and then also Adaptive Biotechnologies, who make the clonoSEQ MRD assay. We also get institutional research funding at Dana-Farber from a variety of different companies to support our clinical trials. So let's just talk at a very high level about how we can measure the burden of disease in oncologic care and in CLL. And we really need to be doing this throughout the course of a patient's disease. And this is how we can understand how much disease is present. And so when patients are first diagnosed, you may remember you had your blood drawn, and that's often the most common way that we discover CLL. And we notice that there's an elevated number of these lymphocyte cells. These are white blood cells that are normally there to help you fight off infections. But when we see them in these high numbers, it suggests that there may be something else going on. And we can actually look under the microscope, as you see on the left, in what's called a blood smear. And those red cells are red blood cells. And the white purplish cells are, in this case, CLL cells. And there should only be a handful of them in a typical blood smear. But for a patient with CLL, it may look like this, where there's quite a few of these cells. And so that's a sort of initial way that we can assess how much disease is present in the blood. As you know, CLL can also involve the lymph nodes and the spleen, which can enlarge. And so we can sometimes detect that on physical exam. But sometimes we also use imaging techniques like CT scans to detect the size of these lymph nodes and spleen. And then in some cases, a bone marrow biopsy can be helpful. You can see that on the right, which looks a little bit different from the blood smear, but kind of a similar concept. You can look at the different types of cells in the bone marrow. This is often helpful in patients who are approaching the need for treatment to figure out if the cause of their anemia or low platelet count is due to CLL cells filling up the bone marrow and kind of gumming up the works to make the normal blood cells. So these are all the different ways that historically we've been able to assess the burden of the leukemia in patients. This helps us to stratify patients by different risk groups. And then once patients start on treatment, it also helps to assess how effective the treatments are. And in patients who are in remission and off treatment, it can be useful to help detect when the disease may recur or come back. So again, there's many different testing modalities that we can use. These are standard tools to help inform the staging of CLL as well as to evaluate the risk. So I'm going to talk in a little bit about multicolor flow cytometry. I'll explain what that is. That's usually the way that we make the diagnosis of CLL, but it can also be a way to look at MRD. Molecular tests, similarly, are going to be a way to look at MRD, so we'll talk about that. I mentioned bone marrow and the complete blood count, CBC. And then FISH testing, many of you are probably aware, is a way to look at the different chromosomes in the CLL cells, and that's more to evaluate the risk for patients rather than the number of CLL cells that are present. So here's another way to kind of think about the patient's journey through the course of the disease, and kind of starting at the time of diagnosis. We make our initial evaluations and try to determine the burden of disease at diagnosis using the techniques we just discussed. And as you're aware, most patients with CLL are able to go on the active surveillance approach, or watch and wait, observation without treatment. And that period can last from a few months to a few years or even longer. And of course, we see patients at a regular interval and do physical examinations and draw blood counts. We try to avoid doing too many invasive tests during this period. So we don't typically need to be getting regular CAT scans or bone marrow biopsies. But as patients approach the need for active treatment, that can be a good time point to get some of those tests, like a bone marrow biopsy or a CAT scan. And then during the phase of active treatment, whether it's by a fixed duration of treatment over a period of 1 year, for example, or whether it's a continuous treatment like the BTK inhibitor drugs like ibrutinib or acalabrutinib, we certainly do like to assess patients throughout the course of their treatment. And really that helps us to understand, is the treatment effective? Is it shrinking the lymph nodes down? Is the white blood cell count eventually coming down? Is the anemia getting better? Is the platelet count higher? These sorts of things. And then for patients who are on time-limited treatments, they will then hopefully be in a remission. And the different disease burden assessments can help us understand how good that remission is, how deep we would say. And I'll explain what I mean by deep in a little bit with some visuals. I think as we'll talk about as we move toward the future, these different assessments of disease burden may actually help us to also understand when might be the best time to stop treatment for a particular patient. For example, waiting until a patient gets to an undetectable MRD state before stopping. And then for these patients who are on time-limited treatments, hopefully they'll be in remission for a long time. But eventually, many patients will experience disease recurrence or progression of the disease, and assessing the disease burden at that point is also quite important to understand sort of what you're dealing with at that point, what the optimal treatment might be, and when that treatment is needed. All right, so I have a few graphics here. They'll kind of come at this concept of MRD from different angles to try to help you understand it. It's not the most intuitive concept, so that's why I like to kind of try to explain it in a few different ways. So really, if you look on the far left here, you can see at the time of diagnosis, if we were to look under a microscope at the blood, we can see a bunch of these healthy kind of greenish blue cells, but then we can see these orange cells, which are the cancerous B cells or CLL cells. And it's usually fairly obvious when a patient is diagnosed and when they're on the observation that there's a relatively large burden of the cancerous B cells. And we don't need any more sophisticated techniques to do that. We can just look under a microscope. However, our treatments have become very effective in CLL, fortunately, and we can get patients into remission. And so if you go to the second column there, you can see that if we look under the microscope, we may only see the green-blue cells there, the healthy cells. We may not see any cancerous B cells. But unfortunately, because we can't see them, just because we can't see them under the microscope, it doesn't mean that they're not there. And in fact, these cells can be present still at very, very tiny levels, what we sort of would say at a molecular level. And that can really only be detected through molecular techniques like minimal residual disease assessment. Sometimes some people will call it measurable residual disease because sometimes it can be more than just minimal. But in most cases, we're really looking at a time period where we expect it to be really a minimal amount of disease. So I'll typically refer to it as minimal residual disease, or MRD. And there's also, some different nomenclature about whether it's MRD negative or MRD undetectable. And I'll touch on that as well. But just briefly, MRD negative is an accurate term, but generally I like to refer to that at a particular threshold of detection based on the test that's being done. Whereas MRD undetectable sort of implies already that based on the testing that's being done, this test cannot detect MRD at that level. And I'll talk about that in the coming slide. All right, so patients, again, will go into remission and hopefully be there for a long time, for several years, but eventually these patients may develop, some patients may develop a relapse. And so MRD assessment can be done and actually begin to detect that before we can even see anything under the microscope. And so that's sort of the third column there, where maybe there's a handful of cells present. Maybe we look and the portion we look at under the microscope, we can't see any of these cancerous B cells, but the MRD technique will pick them up even if we can't see them there. And that's sort of an early warning sign that there's this molecular relapse. And even though the patients usually feel okay at this point and don't necessarily need additional treatment, it's helpful to know that the disease is starting to come back to begin to plan for the next treatment that is needed. And then finally, on the far right, column 4 there, you see clinical relapse. And then we kind of get back to, as we saw at diagnosis, where we can look under the microscope and it's fairly easy to see the disease, and maybe MRD testing is not as necessary there. So that's sort of one way to look at MRD. Here's another conceptual way that I actually really like. And this is where I was saying before, undetectable versus negative. I think this perhaps will help you to understand that concept a little bit better. So this is sort of the inverted iceberg model. So we take an iceberg, we flip it upside down. And at the very top there, we can see at time of diagnosis, there's estimated to be on the order of about 1 × 10 to the 12th CLL cells. So that's about 1 trillion CLL cells in the body. And so again, that's usually pretty easy to detect by standard techniques, including just looking under the microscope. And as a treatment is applied, we can begin to reduce that disease burden by several orders of magnitude. And as the lymph nodes begin to shrink and the blood counts begin to improve, we get into the PR category, or partial response. Eventually, if the treatment is very effective, we can get patients into the CR category of complete response. But note that the CR line there is still above this kind of orange line, which is the level of detection with the microscope. And so it's possible actually to be in a complete remission, but still have detectable MRD that can be detected by these molecular techniques. Now, as you drop below this orange line, you start to get into this MRD state where you can directly measure at a cellular or molecular level the amount of CLL cells that are there, but are not visible under the microscope. And in case you're not sort of a math-oriented person, these orders of magnitude are going down by a power of 10, meaning that if you're looking at MRD at a power of 1 in 10,000, that's getting down to 10 to the -4th level of detection, which you can see is a fairly small amount of disease compared to where you started. But as we'll talk about, some of the newer techniques can get down even into lower levels of detection. 10 to the -6 represents being able to detect 1 in 1 million cells that are CLL cells present. So really a tiny amount of disease there. And so again, going back to this concept of MRD negative versus undetectable, if you're saying MRD negative, you should really be saying which test you're using and at what level. So you could say this is MRD negative at a level of 10 to the -5th using next generation sequencing based assays, which we'll talk about. Or you could just say MRD undetectable, and that sort of implies that whatever the characteristics of the test that you're using, that you can't detect them at that threshold. And sort of my final sort of conceptual slide here about MRD kind of links the depth of response to the time. So this is the slide that to me sort of puts everything together with understanding how MRD can change with the disease burden over time in patients who are undergoing therapy. So on the y-axis vertically here is the tumor load, or the number of tumor cells present. On the x-axis is time, starting at time 0, which is kind of before starting any treatment for CLL, then going on to therapy, and then to the right, time after therapy. And again, using kind of this depth of response threshold model, you can see on the far left, 3 different patients who all start with the same burden of disease, which let's say is 10 to the -2nd, doesn't really matter which level. And you have 3 different clinical courses here. So you have patient 1 who, let's say, has high risk disease. They have this deletion 17p, more aggressive form of CLL, and perhaps they're getting a treatment that's not as effective for that type of disease. And so you can see that treatment will still likely cause some decrease in the tumor burden over time. They kind of get down into this 10 to the -2nd to 10 to the -4th range, and then they stop their treatment. So let's imagine maybe say a patient with high-risk disease treated with chemoimmunotherapy. This is not something we generally do anymore, but in the old days when we only had chemoimmunotherapy, there were patients who unfortunately had this course where they just had a very short time of kind of a partial remission. And then within a few months of finishing the treatment, the curve goes back up and they get back into clinical relapse. Now, you can imagine a patient either with different genetic markers, lower risk disease, or perhaps a patient with higher risk markers who goes on one of our more effective treatments that we have now for high risk disease. So that would be like patient 2. And you can see that patient who starts with the same disease burden has a more rapid reduction of the disease and actually gets to a greater depth of response, down closer to this threshold of 10 to the -4th. And because they get into this deeper response, it then kind of takes longer for them to have clinical relapse. And so they go out, maybe an extra year or two until they have clinical relapse and need additional treatment. And then finally, patient 3 has the best outcomes here, whether it's due to the risk of their disease or the effectiveness of the treatment. They have a very, very deep response. And you can see it then takes a long time for them to have relapse. There's 2 lines coming off of this one because I wanted to kind of illustrate a couple of different examples. So one is a patient, let's say, with higher risk disease. As you probably know, there's patients with IGHV mutated and IGHV unmutated CLL. So let's imagine this first patient scenario of patient with unmutated IGHV CLL, where the disease does tend to grow a little bit more quickly. And so that patient may have time-limited treatment and do very well, and they may stay in remission for several years, but you can see that the slope of that curve suggests that they will relapse within a few years. In contrast, the second line coming off here is a patient with mutated IGHV, where they have a very slow-growing form of CLL. And so even though the depth of response is the same as the patient with unmutated IGHV, because the second patient has lower risk disease biology, it takes a very long time for them to have any relapse. And some of these patients maybe will never relapse. Maybe they'll die of something else, unfortunately, before they relapse, but can take many years to get to relapse. So those are sort of various different scenarios that hopefully help you understand what MRD is measuring. When we're using these fixed duration treatment regimens like chemotherapy or like the Venetoclax-based regimens, what we call UMRD or undetectable MRD is really a key goal of therapy, because the lower you can get here and the more quickly you can get there, we think the longer the remission duration will be without the need for ongoing treatment. Again, not as important if you're going to be on a continuous treatment, because we know those can be very effective even without achieving undetectable MRD, but they do require the ongoing nature of the therapy. Okay, so with that as background, I wanted to jump now into a little more details on some of the MRD assessment methods. There's 3 main ways that we look for MRD. One is flow cytometry, which is a cellular-based assessment. In other words, we're actually counting numbers of cells. There's PCR, which stands for polymerase chain reaction. And this is a way to look for a molecular signature through a DNA sequencing assay. And then the most recent one is called next generation sequencing, or NGS, which is another molecular assay. So it's looking for DNA sequences, but it's doing it in a little bit more of a sophisticated way. Let's talk about each one of these now in a little more detail. So multiparameter flow cytometry, or just flow as we often call it, is a way to look at the pattern of different cell surface proteins that are coming off of the cells. So in the lower left, you can see a CLL cell. It's got a characteristic pattern of different proteins. If you want to get a little bit into the weeds on this, the proteins, for example, could be something like CD20, which marks for a B cell, but also CD5, which is normally a marker for a T cell. So when we see CD5 and CD20 together on the same cell, that's abnormal, and we know it's a CLL cell. So using those markers and a few others, we actually use a technique where we link up antibodies to fluorescent molecules. Fluorescent meaning they can glow in various colors. And so you can see now these antibodies can attach to the proteins of interest on the cell surface. And then we can run these through something called a flow cytometer, which shines laser beams off the cells, and they can refract depending on what fluorescent molecules are attached to the surface of the cell. So CLL cells will refract in this characteristic pattern as they pass through the flow cytometer. And that will give us a clue as to how many CLL cells are there compared to other cells. And in the lower right, you can see how the actual raw data look. And so we can see that the B cells, the CLL cells on the left there, have a particular pattern based on their expression on the X and Y axis. And then the T cells look very different. And this is a way to really very precisely quantitate or count the numbers of cells that are there. So that's all we're doing with flow cytometry. We're counting cells. Now, PCR and NGS, the other 2 techniques, are a little bit more sophisticated. We're not counting cells here, we're sequencing DNA. So how does PCR work? This is really a way to do DNA sequencing of the B cell receptor signaling pathway. In particular, this is a pathway that all the CLL cells generally rely on to survive. And so we can do a DNA sequence of a gene in that pathway. And this will allow us to understand how much of that DNA is present. This is the process. If you've taken molecular biology in the past, there's a denature, anneal, and extend. I wouldn't get too bogged down in the details there, but again, it's just kind of a way to amplify or almost kind of grow up the DNA to allow us to then sequence it and understand how much DNA is there. So because this is a little bit more of an involved process, actually you have to customize it for each patient. These are what's called patient-specific primers to allow you to do the DNA sequencing. So it requires two things. One is a sample to be taken from a patient before they start the treatment, because you need to be able to sequence the tumor. And number two, to be able to amplify that up in a patient-specific way. And then basically the idea is once you've identified the sequence that's there, later on when the disease is in remission, you can draw the blood and look for that same sequence to see if it's still present or not. So a little complicated, but if you understand that, then you'll understand the next generation sequencing, which basically uses a very similar concept. Same thing here, you're sequencing the DNA when you have disease present, and then you're looking for that same sequence later on in patients who are in remission to see if it's there. The reason why this is the next generation of sequencing is because it looks at a different area of sequencing, this so-called VDJ recombination. So this is a pretty cool part of your immune system. So your immune system has these VDJ genes that in normal B lymphocyte cells, they're constantly rearranging. Basically, as lymphocyte cells get exposed to various pathogens like bacteria and viruses, they're supposed to be fighting those off, and they can actually rearrange these VDJs to get more diversity to recognize other pathogens. And because we have these amazing immune systems, the potential diversity of these different rearrangements is on the order of 10 to the 11th. So, about hundreds of billions of different possibilities of rearrangements. And so because there's so many hundreds of billions of different possibilities, if we can identify one of these possibilities that's unique to the CLL cell, and then we go later on and we try to sequence for that, the likelihood that we would detect that same sequence, as we saw initially, is very low if it's not due to CLL. So in other words, if we see that sequence again when we look for the MRD through NGS, then it's almost certainly CLL that's still present. And that allows for much greater power in terms of the depth there. So the flow-based techniques are usually looking in one in 10,000 cells, PCR usually around that same range, sometimes 1 in 100,000. Here with next generation sequencing, we're talking actually closer to 1 in 1 million cells that can be detected. So it's a very powerful technology. The adaptive clonoSEQ is one assay that you may have heard of that's been cleared by the FDA to look at this. There are other assays like that from other companies that are in development, but this is certainly a promising way to look at very deep levels of MRD. So with these different tests available now, how do we select which test should be used in clinical practice? So there's many different test characteristics we need to consider. First is sensitivity. In other words, we want to be able to detect the MRD at these very low levels, as I mentioned, because that can give us even more powerful prediction of who's going to do well over time. But we also need to have what we call specificity, meaning we don't want to have MRD tests that come back falsely positive when they're actually negative. And that's, as we'll talk about, going to be particularly critical as we move toward the future in CLL, where I think the duration of treatment is going to be guided by the MRD test. So we don't want to be under-treating patients who have falsely negative MRD tests. We don't want to over-treat patients who have falsely positive MRD tests. So these test characteristics are very important. We also need to make sure that the test is standardized, and especially if we're going to be making clinical decisions, these need to be very rigorous assays that are reliable. And ultimately, we want to make sure that these assays are having a positive impact for patients. So we need to make sure that the sample types are reasonable. We want to use blood whenever we can instead of bone marrow. We want to make sure that we can draw a reasonable volume of blood that's not too burdensome for patients. These tests can be expensive, and we want to make sure those financial impacts are not put on patients, and that insurance companies will cover these tests. So these are a lot of kind of the real world implications of having MRD testing and important factors to consider as these get rolled out more widely in the disease. All right, so I'm going to switch gears a little bit now and just kind of give you a couple of general examples of where MRD testing can be helpful. First, in the setting of chemoimmunotherapy, since that's where we have the most data for MRD, but then in the second part, I'll talk about Venetoclax-based treatments. So this was a large analysis of over 2,000 patients with CLL who had received chemotherapy-based treatment for their first treatment of CLL. And at the end of that treatment, MRD was measured here by the flow cytometry technique at a power of 1 in 10,000. And they had patients who had undetectable MRD and patients who had detectable MRD at the end of their chemotherapy. And these are curves looking at what we call progression-free survival, which is basically the time from the start of that treatment until the time the patient had a progression event or recurrence of the CLL that required treatment. And you can see here that there were about 1,000 patients in each group, so about half the group had undetectable MRD, half the group had detectable MRD at the end of their initial treatment. And you can see that the patients who had undetectable MRD took much longer until they had progression of the CLL as compared to patients who had detectable MRD. So already this was an initial clue that this was going to be a very important predictor of the duration of the remission after treatment. Then they did an interesting analysis in this study, which was to take all the patients who had achieved a complete response by our international criteria. So by complete response, I mean all the lymph nodes were back to normal size, the spleen was normal size, the blood counts had normalized, and the bone marrow was completely clear under the microscope. But as I mentioned, you could have all those things and be in complete remission, but there could still be a tiny level of disease present molecularly, in other words, MRD detectable disease. And so looking at the, about almost 400 patients who had a complete remission, you can see that the patients who still had detectable disease here, that's the orange line, had a much shorter progression-free survival than the patients who had undetectable MRD. So in other words, even within this group of patients who all did well, they all had a complete remission, there was some additional prognostic power of having the MRD test on top of that. This is a little more complicated here, but I think it's very interesting because there was an analysis done where they pulled together a large group of patients who were treated with chemotherapy for their CLL initially. And they looked by the status, whether they had complete remission or partial remission, and then also whether they had detectable MRD or undetectable MRD. So two of the curves here I think are pretty easy to understand. So one is the orange curve. That's the patients who at the end of treatment had a partial response and detectable MRD. So predictably, those patients, because they didn't have as great of a response, they had a shorter progression-free survival. The other curve I think that's easy to understand is the patients who had an undetectable MRD complete remission. That's kind of the aqua turquoise curve at the top. Those patients had the best possible response. You expect them to do very well. But what I think is kind of interesting here is the two curves in the middle. So you have one curve, which is similar to the one I just showed you. That's the grayish curve, which is patients who had a complete remission, but still had detectable MRD. So their PFS or progression-free survival was kind of somewhere in between. But then the very interesting thing is that you had patients who at the end of treatment only had a partial response, meaning they still had some enlarged lymph nodes or their spleen was still slightly enlarged. But in the blood and the bone marrow, they were able to achieve this undetectable MRD. And those patients did very similarly as patients who had a complete remission and had undetectable MRD. So in other words, what this suggests to me is that actually the MRD test was the one that was a better predictor of the progression event rather than CR versus PR. And so I think that could be relevant for patients, when you reach the end of a time-limited treatment and you're in a partial response, you may actually still enjoy a very long remission if you've been able to achieve undetectable MRD. Now, we've talked before also about the IGHV status. Remember, it can be mutated or unmutated, about a 50-50 split in CLL patients. Mutated usually are patients who have the slower growing form of CLL and usually have a more durable response to chemotherapy. And this graph, I think, is just very provocative. It's very small numbers of patients from this study, but these were all patients treated with the FCR chemotherapy regimen. And this curve at the top, the gray curve, it's only 4 patients, but it's patients who had unmutated IGHV. So you wouldn't expect them to have a very long response to FCR. But 6-7 years out, they're all still in remission. And these are the patients who achieved undetectable MRD. So at least at the end of treatment, by checking MRD status, it suggests that it may be more powerful than the IGHV mutation status at that time point in terms of predicting who's going to have a more durable response. There's also some emerging data suggesting that the deeper levels of MRD may actually be better predictors of progression-free survival than even lower level regular MRD testing, like the flow-based testing. And so these are a small number of patients here. They had testing on the bone marrow in the curves on the left and in the blood in the curves on the right. And in both cases, you can see that patients who had detectable MRD at a level above that 1 in a million, that's the orange lines, had a shorter progression-free survival than the patients who had undetectable MRD at a level of 1 in a million, that's the top line. So again, suggesting that even within testing of MRD, the depth of testing may actually be very helpful in terms of predicting outcomes. So based on these and other data from the chemotherapy era, the various recommendations have been to include MRD assessments in assessments of disease response. There's something called the NCCN, which is the National Comprehensive Cancer Network, which makes guidelines for CLL. So they include this in their guidelines. The IWCLL, International Workshop for CLL, also includes MRD in the guidelines as a desired endpoint in CLL. And so this is something that's very widely incorporated into clinical trials. As we'll discuss, probably it's not as routinely incorporated yet into clinical practice, but I do think as we move toward the future that more MRD testing will be done in routine clinical practice, even outside of clinical trials. So you may be wondering at this point, why do I care as much about MRD and chemotherapy? We're not using chemotherapy as much anymore these days in CLL, which is true, and that's certainly a good thing. But now I'll show you some data from the Venetoclax era suggesting that some of those lessons that we learned from chemoimmunotherapy and MRD may actually be directly applicable to the time-limited therapies that we now have with Venetoclax. So this is the scheme for a study called CLL14. This is the trial that led to the approval of Venetoclax with obinutuzumab, an antibody infusion for the initial treatment of CLL. And the treatment is about a 1-year combination of those drugs, actually 6 months of combination followed by about 6 months of Venetoclax as a single agent. And this was compared to a 1-year course of obinutuzumab with the older chemotherapy drug chlorambucil. And the point here in this study is that there's a lot of these yellow circles, which represent MRD assessments in the blood that were done about every 3 months in patients in both arms of this study. And so one thing that came out from here, again, looking at progression-free survival over time, and I'll encourage you here to focus more on the solid lines, those are the Venetoclax treated patients, is that, again, the depth of the MRD attainment was correlated with better progression-free survival. So looking at the top here, this solid purplish line is patients who were treated with Venetoclax-based treatment and achieved undetectable MRD. So you can see these patients have done very well. Upwards of close to 90% of these patients are still in remission at 36 months, 3 years. Then you have the patients with sort of a low level of MRD that's detectable there, but not very high. And those patients did okay, but most of them did actually begin to have progression of the CLL within a couple of years after finishing the Venetoclax treatment. And then you have this smaller group of patients in the solid orange line who unfortunately still had high levels of MRD at the end of the year of treatment. And you can see most of those patients within a year of finishing treatment had progression of the CLL and would go on to need additional therapy. Now, what about that concept before I mentioned of complete remission, partial remission versus MRD, which is more important? And so we saw with chemotherapy that actually MRD was more important. And so far the same seems to be the case here with Venetoclax. So these are again data from the CLL14 study. Again, like we saw before, the solid kind of aqua curve here is patients who had a PR, partial response, with detectable MRD at the end of treatment. So they had the shortest benefit from the treatment. Then you had the patients with a CR who had undetectable MRD. That's the dotted purple line at the top. And of course, those patients did very well. And I think importantly, again, this dotted turquoise line here is the patients who had a PR, partial response, but they had undetectable MRD. And those patients seem to do just as well as those patients with a CR, complete response, and undetectable MRD. So again, suggesting that here in the Venetoclax era now, it's actually the MRD test rather than complete versus partial response, which can be the most predictive of the duration of that response. So I won't get into too much depth here because this starts to get a little bit more nuanced, but just to kind of highlight that one of the things that we're doing now in trials is not just looking at MRD at a single time point, but looking at MRD over time and how it changes. And we're also finding that there's patients who have so-called positive growth of their CLL while being on treatment, and then patients who have negative growth. What that means is that the positive growth patients actually have increasing levels of MRD despite being on treatment. Negative growth is patients where the MRD level is decreasing while they're on treatment. So that's obviously a preferred situation. And then we can look on the right at the progression-free survival based on the growth rates. And we do see a difference in terms of even patients who have undetectable MRD, if they've had a higher growth rate, they have a shorter progression-free survival. In patients who have detectable MRD, it's the same thing. Patients who have a higher growth rate of the MRD have a shorter progression-free survival. So this suggests that there may actually be benefit to measuring MRD over time to even further refine our predictions about when patients may need additional therapy. So MRD has also been assessed quite rigorously in patients who have relapsed CLL, meaning patients who were treated with something, usually chemotherapy, and then had a recurrence of CLL, it came back. And the MURANO study then treated these patients with a 2-year course of Venetoclax with the first 6 months, including rituximab infusions. And this was compared to a 6-month course of chemo with bendamustine and rituximab. Again, in this study, the same concept, patients who had a partial response but had undetectable MRD, that's the dotted kind of purplish curve here. with 86 patients, they did just as well as patients who had a complete remission with undetectable MRD. So the same pattern emerging again, MRD more predictive than a complete versus partial remission. So where are we headed with all this in CLL? Right now, as you may be aware, the data that I just showed you with Venetoclax, all the Venetoclax-based regimens have been 1 year for patients who have not had prior treatment or 2 years for patients who have had prior treatment. So in other words, every patient gets the same duration of therapy in each line of therapy. So I'm showing you these 3 studies here just to highlight sort of the tip of the iceberg, so to speak, because most of the studies now going forward in CLL are looking at what we call MRD adapted therapy or MRD driven treatment decisions. So the Captivate study looks at a combination of ibrutinib with venetoclax. All of the patients get 15 months of therapy, but then if patients get to undetectable MRD, they get randomized in this trial. So half the group gets ibrutinib continuously, and then half the group gets a placebo, because we really don't know if additional ibrutinib is going to be helpful for these patients. And this is the only way we're going to understand that. In the MRD detectable group, we're worried that these patients still have detectable disease and they probably do need some additional therapy. So those patients are being randomized to continue on either just ibrutinib or ibrutinib with venetoclax. And we've started to see some of the data reading out from this trial. It's very early. So far, there aren't any major differences in that progression-free survival between the different randomized groups. But again, this is the type of study where using the MRD test is going to help us to understand how much therapy is needed for a particular patient. We know that these 2 drug regimens are effective. There's also some excitement now about 3 drug novel agent regimens. And I'll just highlight 2 of them here. One is called the Bovin study, which combines a newer BTK inhibitor called zanubrutinib with venetoclax and obinutuzumab. And then our study that we've been running at Dana-Farber and we recently published, which is called the AVO study, combining another BTK inhibitor, acalabrutinib with venetoclax and obinutuzumab. And I highlight both of these so-called triplet studies with 3 drugs because both of them use the MRD test to guide the duration of therapy. I'll just give you our study as an example. All the patients on our study get 15 months of treatment. If they have undetectable MRD at that point, they can stop the treatment and go on watch and wait again. And we think those patients will do very well because they've achieved undetectable MRD. But if they haven't quite gotten there by the end of 15 months, then they can go on to get an additional 9 months of venetoclax with acalabrutinib. And so then after 2 years, they actually can stop treatment if they have undetectable MRD. But if they still have detectable MRD at that point, we encourage them to stay on the acalabrutinib and venetoclax, hoping to continue to control the disease. So you can see there's a number of different ways that this can be done. And there's future larger studies that are looking at these questions of what's the best way to use MRD as a way to make clinical decisions and to guide patients as to the optimal therapy duration. But really this, without getting too bogged down in the details here, the idea here is just to illustrate to you that I do think this is going to be the future of CLL. It's not going to be 1 year of treatment for everyone getting first therapy. It's going to be, well, 1 year if you're doing very well, but maybe 2 years if you need a little more therapy. Heck, maybe if you do very well, you only need 8 months of therapy and we can spare you the additional side effects and costs of additional therapy. So I think this will be a way to really individualize and personalize therapy for patients rather than more of a one-size-fits-all mentality. And this is really just to highlight the growing interest in MRD within the field. These are the numbers of CLL trials that have incorporated MRD as an endpoint. You can see MRD is an old technology. It goes back to the 70s, actually, when it first entered the clinic looking at chemotherapy, but very few studies were utilizing it. It was really when we got into the 90s when we had more powerful chemotherapy-based regimens that the interest grew. And you can see as the FCR era dawned in the early 2000s, that's when we really began to have a lot of clinical trials launching that looked at MRD using an endpoint. And then I think there's been this new burst of studies looking at MRD based on the venetoclax approval. And you can see by the late 20-teens that there were over 550 studies on CLL that have looked at specifically this MRD endpoint. So I thought it'd be helpful as we wrap up here before we get to questions to go through some specific patient vignettes to help you understand some of the areas where MRD testing may be helpful kind of from a more practical perspective. So first patient is a 66-year-old man who is diagnosed with CLL, was actually originally diagnosed at age 59 with unmutated IGHV, so a little more steadily progressive CLL, and did require treatment fairly soon after diagnosis and was treated with the FCR chemo at that time point. Now you can see that this patient at time point 1 in the graph on the right had a fairly high number of CLL cells. but did well with the initial therapy. And by time point 2, was in this kind of almost MRD negative state, although by flow cytometry, there was still a little bit of MRD present. And so at that point, it was kind of predicted that because the patient wasn't completely undetectable for MRD, that it was likely within 2 to 3 years that they might need additional treatment. This patient decided they wanted to get MRD testing done every 6 months. And you can see it stayed at that same level in time points 2 through 6. But then at time point 7 and 8, it began to creep up. By time point 9, it began to be more obvious that the patient had recurrent disease. And at time point 10, the patient had a fair amount of disease present and required therapy. Now, interestingly, this patient went on Venetoclax with rituximab. And you can see by time point 12, had a very deep remission that was undetectable for MRD, even a deeper remission than they had achieved initially with FCR. And the patient and the oncologist at this point were able to meet and understand that by getting to this undetectable MRD level, it was likely the patient was going to go into remission for a longer period of time. And it was helpful for this particular patient who was kind of thinking about retirement. They were in their late 60s and wanted to work for a couple more years, but also have some time for retirement and not have to worry about treatment. And they felt more comfortable at that point, doing a couple more years of work, knowing that it was likely they would have a several-year-long remission. So this is a 65-year-old woman, second case here. This patient had standard FISH testing and had previously had some chemotherapy and then presented to the oncologist with the need for second line of treatment for recurrent disease. So went on Venetoclax with rituximab. Before starting the therapy, the oncologist sent an ID sample, that's time point 1 here. So the ID sample, remember, if you're using a more sophisticated next generation sequencing approach, you need to look for that sequence when there's still disease present. You got to remember to send that sample before starting treatment. So that was done. The patient received the 2 years of Venetoclax plus rituximab. And at the end of that 2 years, at the time point 2 here, this patient had a next generation sequencing based MRD assay sent. And this showed that the patient had achieved undetectable MRD at a level of 10 to the minus 6, in other words, 1 in a million cells. So this is a very deep remission. And this is a patient where it would be predicted they would have several years of remission after finishing Venetoclax off the treatment. And you can see this patient wanted to have testing done once per year. And it's so far at time points 3 and 4 has had undetectable MRD that's ongoing at this very low level. So this patient felt very comforted by the fact that there was no early evidence of recurrence and that they could continue to live their life to the fullest and not have to worry about receiving any additional treatment anytime soon. So the final patient here is a little bit more of an unusual CLL patient based on his age. So he was only 42 years old when he was diagnosed. Had high-risk disease, unfortunately, and was started on a Venetoclax-based treatment on a clinical trial, actually, before Venetoclax was even approved. This was back in 2013. His oncologist did send an identification sample for next-generation sequencing, and the patient completed a standard 1-year course of Venetoclax with obinutuzumab, and fortunately was able to achieve this undetectable MRD at the 1 in a million mark. This is time point 2. This patient was very anxious to understand the dynamics of the MRD test and wanted testing done every 6 months. And so you can see several different time points done here. Little triangles over time indicate different MRD tests, which were all undetectable at 10 to the minus 6, 1 in a million cells. But unfortunately, in mid-2018, test 3 did come back low-level positive. And by January of 2019, time point 4, it was pretty clearly detectable MRD at that time point. So this is a patient who did not necessarily need treatment based on time point 4. They were actually still feeling well. They didn't have much in the way of lymph node disease. Their blood counts otherwise looked okay. So we weren't using MRD here to make a decision about restarting treatment, but we were using it to begin to plan because this patient had young children, had work obligations, had a lot going on, and appreciated the fact that there was sort of this early warning system that, okay, your MRD is positive, likely in the next few months, you may need some treatment, maybe a good time to start looking into clinical trial options if you don't have those available with your current oncologist. And so this was helpful for this patient in terms of planning and being able to understand what their treatment options were going forward. All right, so hopefully that was sort of a helpful review of the concepts, the clinical data, and then some specific patient examples focused all on MRD. Summarizing all this, I would say that MRD clearly does provide additional insights beyond the conventional CLL response assessments like blood counts and CAT scans and bone marrow biopsies. We can see really across the different therapies, whether it's chemotherapy or Venetoclax-based treatment, that patients who achieve MRD negativity have improved long-term outcomes in terms of this measure of progression-free survival. And that when we can test MRD at even lower thresholds, i.e. 1 in a million, these patients may have even further improvement in their outcomes compared to those patients who achieve undetectable MRD at higher thresholds with some of the older techniques like flow cytometry. We talked about several of the different testing methodologies that are available. There are certainly pros and cons to these different techniques, and we have to select them based on the clinical needs of the patients, some of the technical and practical considerations, and some of the other testing parameters as listed here. But I think that right now already in the context of patient care, there's several ways in which MRD may be useful to inform CLL management. As a reminder, and I've said this a couple of times, there's other scenarios where MRD is not useful to inform CLL management. Again, the main example there being patients who are doing very well on the BTK inhibitor drugs, really not helpful to test MRD because most patients will have detectable MRD and they can continue to do very well as long as they continue to take their BTK inhibitor drug. But I talked about a few examples of where MRD may be useful in particularly the Venetoclax combination approach to understand the prognosis of patients who have completed that treatment, to help understand when disease recurrence may occur and when additional therapy may be needed. And with some of the trials that I highlighted there at the end, I tried to give you this sense that I think over the next few years that MRD will be playing an even more important role in CLL treatment, because I do really think it's going to be used to help us understand what the optimal duration of therapy is for a particular patient. And this can really be done in a patient-by-patient fashion, which really will allow us to individualize the therapies for patients, making sure that we're giving patients who have more resistant disease a longer duration of therapy, but also making sure that we're not over-treating patients and that patients who have more sensitive disease may be able to enjoy a very long remission, even with a shorter course of therapy. All right, so with that, I'm happy to take any questions, and thank you very much for your attention.
Thank you so much for that presentation. We already have a few questions in the Q&A. The first one is about overall survival and progression-free survival. What is your view, and when do you think we might have precision on these MRD measurements?
Yeah, so in terms of progression-free survival, I think we're certainly getting there very quickly. Based on the data that I showed you from the Venetoclax obinutuzumab CLL14 trial, and based on some other emerging data that's coming out from some of the BTK inhibitor plus Venetoclax combinations, I think that we're clearly seeing that patients who have deeper MRD responses are having longer progression-free survival. The good news is that overall survival is very long in CLL, meaning patients are living for a very long time. And so it's too early to know whether that's going to translate into overall survival differences. That does seem to be the case from chemotherapy-based studies where MRD does correlate with overall survival, but it's too early to know whether that's the case with Venetoclax-based treatment.
And can you clarify the partial response, but still not having undetectable MRD?
Yeah, I'm glad you brought this up because this is a point of confusion, sometimes even for oncologists who are not taking care of as many CLL patients. So basically, the idea here is that these are what we call sort of orthogonal measures of response. So in other words, they're measuring different things. So when you're looking at a patient who's had a partial response, it means that they've had an improvement in their blood counts, they've had a shrinkage of lymph nodes and spleen, but that they're not completely back to normal size. When you're measuring MRD, you're looking just in the blood or just in the bone marrow, whether you can detect the cells at a molecular level. So sort of the easiest example, I think, to imagine is a patient who starts with a very large amount of lymph node disease. Let's say they have 12 centimeter lymph nodes when they start treatment. They have a great response to treatment. All the lymph nodes shrink down. Now they're only 1.7 centimeters in maximum dimension, and the MRD test is undetectable. So technically, to get into a complete response category, all the lymph nodes need to be less than 1.5 centimeters. So because this patient has lymph nodes of 1.7 centimeters, they're in a partial remission, not a complete remission. But we don't know that those remaining 0.2 centimeters are actually active CLL cells. So sometimes you can see, for example, scar tissue, which can be a little bit larger. It's actually just dead cells. And so this patient may have undetectable MRD. They're in a great remission, but technically they're still in a partial remission by the criteria. And that might be one of the reasons why the MRD actually is a better predictor of response, because it can kind of help overcome some of these limitations of CAT scans and partial response versus complete response.
Great, thank you. And for our next question, why would my oncologist not do an MRD test after radiation for stage 1 grade 3A follicular lymphoma?
Yeah, so follicular lymphoma is more of a true lymphoma where it tends to be more of a lymph node focused disease. It's very sort of uncommon to have circulating disease in the blood. So MRD testing is not really used widely in follicular lymphoma. So really focus on MRD testing in lymphomas, even though CLL is considered a type of lymphoma. It's been more in CLL because there's much more of a predilection for the disease to circulate in the blood, and therefore MRD is much more reliable in CLL.
Thank you. And for our next question, is MRD considered to be more accurate measured via bone marrow biopsy rather than blood?
So historically, that was the case, particularly in the chemotherapy era where we were using a lot of rituximab. So when you checked MRD at the end of chemoimmunotherapy with rituximab, it would sort of actually, the rituximab would kind of falsely clear the blood, but there would still be disease left in the bone marrow. And so you could check in the marrow and you could see detectable MRD, but you checked in the blood and you didn't see it. But then if you checked 6 months later, once the antibody had cleared out of the system, you would see the cells come back into the blood. So historically, that's why a lot of bone marrow-based MRD testing was done. So this has been an area of focus with the Venetoclax-based studies. And maybe it's because Venetoclax is more effective than the chemotherapy and it can eradicate bone marrow disease more effectively. But so far, what we've seen is around a 90% concordance in most of the studies between blood and bone marrow assessments of MRD. And that's probably going to be even a higher correlation when looking with next generation sequencing-based technologies. So if you can get that level of correlation with blood and marrow, certainly preferable from a patient perspective, I would think, but certainly also from our perspective to spare patients the need for bone marrow biopsies. And because the new testing is getting so good, I'm actually hoping it's going to be able to reduce the need for bone marrow biopsies going forward. I don't know that we're completely there yet, at least in the clinical trial setting. It's important for us to continue to get the bone marrow biopsies to verify that this is really the case. But hopefully, eventually, once we gather enough data, then in clinical practice, we can really strongly say that we don't need to do bone marrow biopsies. And I'm hoping that that day is not too far away.
Great, thank you. And for our next question, would MRD possibly be more useful or helpful for non-BTK treatment modalities, which are to be taken indefinitely?
I think generally for any treatment modality that's meant to be taken indefinitely, probably MRD is not going to be helpful unless there's sort of a regimen where you can see very, very deep responses with an indefinite regimen. And then you could imagine using MRD as a way to stop. I'll give you one example. So there's the acalabrutinib with obinutuzumab regimen. That particular combination, by using the two drugs, you can get patients sometimes into an undetectable MRD state. And the way that regimen was developed is that you then continue the acalabrutinib forever, afterwards. But there is interest, and there's trials now getting off the ground to look specifically at that combination to see if, for the patients who get to undetectable MRD, whether you could actually safely stop the acalabrutinib and not have to have an indefinite therapy. So that right now is really more of a clinical trial question. Not yet ready to make that change in practice.
Our next question is, can Venetoclax be used again after recurrence if there's a negative MRD testing after previous regimen?
Yes, so specifically, this question is around the Venetoclax plus obinutuzumab regimen. And I would say that in that context, we don't yet have data to understand how effective a second round of Venetoclax plus obinutuzumab would be in patients who've had undetectable MRD after the first round. From the MURANO data set in the relapse setting with Venetoclax plus rituximab, we have a small number of patients. It's about 18 patients so far who've been in that scenario who've been retreated with Venetoclax. And about 3/4 of those patients will have a good response to a second round of Venetoclax. My guess is that in the initial treatment setting after Venetoclax plus obinutuzumab, those numbers will look even better. So I think it's a very promising strategy. I'll highlight that actually we've been developing a study over the last couple of years in collaboration with the German CLL study group that's going to look specifically at this question. It's called the REVENGE study, and it stands for retreatment with VEN-G. GA101 is the old name for obinutuzumab. So a little bit of, I hope, a catchy name. The REVENGE study is hopefully going to be opening early next year. And it's going to specifically look at this question of how effective is it to retreat patients with Venetoclax plus obinutuzumab a second time. And so if you're a patient who's been on that Venetoclax plus obinutuzumab regimen and you're in remission now, you have to have been in remission for at least 1 year. And then if you do have recurrence of the CLL, you'd be eligible for that study. We will have a few sites open around the United States, including at Dana-Farber in Boston, So if that's something that's of interest to you, I think it would be a great clinical trial to participate in.
Great. And one more question I see. Over 2 years ago, I was treated for a CLL and have been asymptomatic since. Is it advisable to get a MRD test to see if the cancer has or will return?
Yeah, so if you have not had the identification sample sent before you started treatment, which it sounds like you probably have not, that's not being done very commonly outside of major academic centers that are doing research here, then yes, you could have MRD testing, but it would have to be the flow cytometry based testing. And that would be at that level of 1 in 10,000. So it's still a very good test and very feasible to do, even if it wasn't sort of planned to look at it originally. The power may not be quite as much as the more sophisticated sequencing test, but certainly could be something to discuss with your oncologist to be tested. I think that I would say that there are patients who still have detectable MRD and are still doing very well. So I wouldn't get as anxious about whether you're positive or negative or detectable or undetectable. Even if it comes back detectable, you could still do very well and not need treatment for a while. But perhaps if it is undetectable, it gives you a little more confidence that you will enjoy a longer remission. So I think there's definitely value in talking about that with your oncologist.
Great. That looks like our last question. So thank you so much for that excellent presentation and answering those great questions. As a reminder to everyone, this will be on our platform for the next month or so. And our next session will be at 1:15 for our Living with Lymphoma breakouts. Thank you again, Dr. Davids.
All right, thanks so much.